Okay. On behalf of the University of Wisconsin and Qualis Transport Solutions, I'd like to welcome you to today's talk, Cholestatic Hepatotoxicity, Integrating Transporter Inhibition and FXR Mediated Regulation. I'm your host, Eric Buxton. Today's talk is presented by Dr. Kenneth Brower, who has over 25 years experience in preclinical drug development and is co-founder of Qualis, a provider of hepatic drug transporter products and research services. Prior to founding Qualis, Dr. Brower served as Executive Director of Drug Metabolism Pharmacokinetics at PPD Discovery, where he directed research in metabolism, pharmacokinetics, toxicology, and absorption technologies. Previously, he served as Director of Preclinical Development, Drug Metabolism Pharmacokinetics at GlaxoSmithKline, and was responsible for the drug metabolism and pharmacokinetics strategy leading to candidate selection, review of candidate project plans prior to candidate selection, and developing and implementing process to ensure a smooth transition from candidate selection to full development. Dr. Brower has over 25 publications in peer-reviewed journals and holds 2 patents, serves on the editorial advisory board for the Journal of Pharmaceutical Sciences, and is adjunct faculty member in the Division of Drug Delivery and Disposition at the School of Pharmacy, University of North Carolina. Dr. Brower?
Thank you, Eric. And as you can see, I'm going to be talking about cholestatic hepatotoxicity today and integrating transporter inhibition and FXR mediated regulation. So first of all, why is this important? Cholestatic hepatotoxicity and drug-induced liver injury is one of the leading causes for acute liver failure in the U.S. And it's also the #1 cause of regulatory actions and drug failure in clinical trials. In addition to drugs, the increasing use of herbals and dietary supplements also contribute to this and are actually the 2nd leading cause for liver injury worldwide. The drug-induced liver injury from many drugs involves cholestasis, and that's what we'll be focusing on today. And the hepatocyte in the liver has a unique ability to adapt to some of these effects, and this adaptation can mean the difference between the hepatocyte dying and its survival. And this adaptive response, as we call it by the liver, is an important component in being able to predict the potential of a compound for cholestatic hepatotoxicity. So in the past, we looked at predicting drug-induced liver injury, and the hypothesis was that if your compound inhibits BSEP, this results in a buildup of bile acids inside the hepatocyte, which are essentially detergents and dissolved membranes at very high concentrations, and this leads to hepatotoxicity. And the question is, can we use this to predict clinical drug-induced liver injury? And a number of investigators have looked at this. I have one reference here by Dawson, but also Ryan Morgan has a nice publication that has looked at this also. And you can see here there's not a very good correlation between the potency or potential of a compound to inhibit BSEP and its potential to cause cholestatic drug-induced liver injury. In fact, there are a number of false negatives and a number of false positives. And in our work on this, the conclusion that we came to is that because the liver can compensate for these high bile acid concentrations up to a certain point, just inhibition of BSEP by itself is not enough to lead to drug-induced liver injury. And so what do we need, what types of systems do we need in order to evaluate this and predict some of these? And the first thing that we really need is a polarized system, because we need to have transporter function both on the uptake side into the hepatocyte and efflux out of the hepatocyte. Plated hepatocytes won't work for this because this is a non-polarized system. There's no bile pocket formation, and all of the canalicular efflux transporters are internalized and not functioning. So simply put, compounds such as bile acids can get into the hepatocyte, but they can't get out of the hepatocyte for that. And that's one of the reasons the sandwich cultured system was developed. And it's an example of a system where you have the cell polarity reestablished. So you have uptake and efflux transporters functioning. Compounds such as bile acids can get in, but they can also get out and be excreted into these bile pockets. And so having this balance of uptake and efflux transporters generates intracellular concentrations that are more relevant to the in vivo or clinical situation. Now, an example of this is if we look at bile acid toxicity in these different systems. So if you look at bile acid toxicity in a plated hepatocyte system, again, the bile acids are taken up by NTCP, transported into the hepatocyte. They have no way of getting out of the hepatocyte because the canalicular efflux transporters, such as BSEP, are internalized and not functioning. So you generate very, very high intracellular concentrations of these bile acids. And we've shown this when we do an exposure study with a model bile acid such as CDCA. When we increase the concentration of CDCA, we see a very significant and rapid toxicity response for that. So the bile acid gets into the hepatocyte, it can't get out, very high intracellular concentrations, you generate significant hepatotoxicity. If instead we use a system that has functioning uptake and efflux transporters, now the bile acids can get in, but they can also get out of the hepatocyte. So the intracellular concentration of these bile acids are much lower. And as you can see here, we have much less toxicity. In fact, there's no toxicity over this concentration range for CDCA. So that's it's very important to have the right system when you're trying to identify what's going on. And a polarized system is essential for this. So with bile acids, we know a lot about bile acids. They're obviously synthesized in the liver. They're excreted into the bile. They're reabsorbed very efficiently from the small intestine and then returned to the liver via the portal circulation, where they're again taken up by transporters and excreted from the liver by transporters. They function to aid in the digestion and absorption of fats and lipids, and increasingly it's become recognized that they're also signaling agents for many of the important processes that occur in the body and in the liver, including regulation of lipids and glucose, and also in the areas of drug metabolism and detoxification. It's important, as we heard in the last seminar, that there are species differences in how these bile acids are handled in both the synthesis, in the metabolism, in the transport, and in their regulation. So it's very important to have a clinically relevant model for this, and that's one of the reasons that we focused very extensively on human hepatocytes for this. Bile acids are also very tightly regulated in this, and it's all through FXR. When you activate FXR, you get increased FGF19. Most of this, it comes from the gut, but the liver is also capable of making FGF19. FGF19 will interact through the surface receptor, FGFR4, and will lead to a suppression of CYP7A1 and also induction of other pathways, including transporters such as BSEP, MDR3, which is a phospholipid flippase, and as I'll show you later today, basolateral efflux transporters, primarily OST alpha and beta. So you can see there's a lot of potential areas that drugs can impact for this, including the canalicular efflux transporters, the basolateral efflux transporters, and the synthesis of these bile acids. And it's important to note in the normal state, most of the bile acids, about 75% of the clearance is through BSEP into the bile, but there is a component of basolateral efflux transport, and that's thought to be through MRP3, MRP4 for this. The reabsorption of these bile acids is very efficient, so that the CYP7A1, the synthesis needs to only occur to the extent of about 5% of the bile acid pool in a 24-hour period. So it's very, the uptake and efflux and transport of these bile acids in both the intestine and the liver is very efficient. Many years ago, we got asked a question: does the regulation process, is that functioning in these hepatocytes? And so one of the early experiments that we did was looking and asking the question of, if we expose these hepatocytes to FGF19 or an FGFR4 inhibitor, will we see changes in the bile acids? And so at that time, we had developed assays to look at the endogenous bile acids, and these include both cholic acid and chenodeoxycholic acid and their glycine and taurine conjugates. So the assay that we developed looked at 6 different endogenously generated bile acids. And if we add FGF19 to this system, and this is all in sandwich cultured human hepatocytes, we see a decrease in the intracellular accumulation and the total accumulation of endogenous bile acids. So the total bile acid mass is represented by the teal color here, and it's decreased to about 40% of control. So when we expose these hepatocytes to FGF19, it interacts through FXR and causes a decrease in the, in this case, we're looking at the functional measurement here. So it's decreasing the function and the synthesis of CYP7A1, and we see that as a decrease in the total bile acid mass and also in the total amount accumulated in the hepatocyte and the bile pocket. So just showing that when we add FGF19, we're seeing the effect that we expect. Also, if we inhibit FGFR4, so FGFR4 is a surface receptor that would take up FGF19. If we block that, we now see an increase in the endogenous bile acids, both in the total here to about 160% of control, and also if we're just looking specifically at GCA, which is one of the more predominant bile acids, we also see very significant increases in the intracellular concentration of those bile acids. So the other important point to make is that we're affecting the amount of endogenous bile acids that are formed through CYP7A1, but under these conditions, we're not affecting the efflux, and so that's represented here in green. The biliary excretion index of these bile acids isn't changing, so we're affecting the synthesis under each of these conditions, but we're not affecting the transport of that, and that's a very important point to get across. In addition, we can link these functional changes to changes in messenger RNA. So here, if we just look at the changes in messenger RNA, we see relative to control, if we treat with FGF19, we decrease the expression of CYP7A1. And if we treat with an FGFR4 inhibitor in the presence of FGF19, we can get most of that back. So it's the message is then reflecting the function, or the function is reflecting the message in this case. And so we've shown that there's some regulation that can go on with these bile acids. We then wanted to ask the question, well, is there transporter regulation also that's occurring under these conditions? And so what we did in this next set of experiments is to use two compounds, one obeticholic acid, which is being developed by Intercept, and also a comparison or a standard positive control for this, which was CDCA. And so in these experiments, we used human hepatocytes, and we looked at the potential of both OCA and CDCA to alter the transporter expression and hepatobiliary disposition of endogenous bile acids. And the study design was very simple and similar to an induction study. We did this in a 24-well plate format. We treated and exposed these hepatocytes for 72 hours. And we used different concentrations of OCA and CDCA because previous studies have shown that OCA was approximately 100 times more potent than CDCA. And in this next set of slides that I'm going to show you, we measured the transporter expression by messenger RNA, and we also measured transporter function either through analysis of exogenously administered bile acids such as D8 tarcholate or D5 CDCA, and the endogenous bile acid disposition that I referred to earlier. So when we look at the dose response for obeticholic acid and chenodeoxycholic acid on these various transporters, a couple of points I want to make here. The different colors represent different donors, and these are all human hepatocytes, cryopreserved, and then sandwich cultured. And the error bars there represent triplicate measurements from each donor. The other thing I want to make clear is that over this concentration range for these compounds, there was no direct hepatotoxicity observed for this, so that the effects that you see are due to the compounds and not a hepatotoxic response from the hepatocyte. So first of all, what didn't change? So there was no change, as I'm showing here, in NTCP messenger RNA, and we define a change as anything over twofold for this, so no real change in NTCP expression, which is responsible for the uptake, some of the uptake of bile acids. Other transporters we looked at included the OATPs and MRP3 and MRP4. We saw no change in those. And also some canalicular efflux transporters, including PGP, BCRP, and MRP2. Again, we saw no changes in those over the concentration ranges that we looked at. So what did we see changes in? So if we look at FGF19, we saw a very nice induction of FGF19 for both OCA and CDCA, very potent inducers of FGF19. Not shown here, but we also saw similar changes for SHIP, which is another important regulatory factor in the process. When we looked at CYP7A1, we saw a decreased expression of CYP7A1 for both OCA and CDCA treatments. And if I just blow up that graph, you can see that we were starting to see changes with OCA at 0.3 or 0.03 micromolar, and with CDCA somewhere around 3 micromolar for that. So that was very consistent with the different potencies for these compounds. We could also link these changes in message with a functional correlation or changed in the amount of total endogenous bile acids for both of these. So that correlated very well with that. So you decrease CYP7A1 expression, you decrease function, and that's reflected by decreases in the total amounts of endogenous bile acids. And we analyze that both in the cell, in the bile, and in the media, since it's found in all 3 compartments. We also observed very nice changes in BSEP expression, dose-related, both for OCA and for CDCA for that. And so in response to high intracellular concentrations of bile acids, remember we're adding bile acids here, the hepatocyte responds by, as I've shown you, decreasing the synthesis of these bile acids through CYP7A1, and then increasing the canalicular efflux of these bile acids. So again, that's the primary pathway out of the cell, so it's increasing the canalicular efflux. In addition to increasing the canalicular efflux through BSEP, we're also increasing the expression of OST alpha, as you can see here, by about 10-fold with OCA, and similar extent with CDCA, although the potency difference is there again. And we're seeing a very nice dose response in the expression changes of OST beta. So OST alpha and OST beta function as a dimer to transport bile acids from the inside of the cell to the outside of the cell, so across the basolateral membrane. You notice there's much more induction of OST beta relative to alpha, and that's because you need to have similar amounts for them to have maximal function. And so initially beta is there to a much less extent than alpha, and so we see more induction of beta relative to alpha, but in the induced state you have similar amounts of each transporter, and that's when you have the maximal function for that. And this induction then translates into a net decrease in the uptake of bile acids, because remember, we did not see any change in the NTCP expression, but we do see an increase in the expression and function of the OST alpha and beta, the basolateral efflux transporters for this. And this increase in OST alpha and beta then correlated with an increase in the media concentrations of these endogenous bile acids. So again, we're linking function with message here. And if we look at here the increase in the basolateral efflux of these endogenous bile acids, again, we're looking at the 6 total, we're looking at total concentrations of all of these bile acids. And this is just a 24-hour snapshot of that, but you can see here compared to control in the cell culture media, we see about a 20% increase in the endogenous bile acids that are found in the media for this. So the next question that we had, we saw these changes after 72 hours, and we really wanted to know, well, how fast does this happen? And so the next set of studies we did was focused on the time course of this response. And so, again, we're using human sandwich cultured hepatocytes. We're looking at a time window now all the way from 1 hour out to 72 hours. And again, we're monitoring gene expression for this and endogenously generated bile acids, the primary bile acids and their taurine and glycine conjugates. And when we do those studies by increasing, we expose to CDCA for various time points, various time windows, and the response we see was actually, it was a lot faster than what we had anticipated. So if we look at here in the response for message of CYP7A1, we can observe these changes as early as 3 hours in that, so very rapid response. Likewise, if we look at BSEP, again, we look at if our criteria is a twofold change, somewhere between 3 and 6 hours, we're seeing an effect on BSEP upregulation. And likewise with OST alpha and beta, again, that coming on board between 3 and 6 hours. So very rapid response by the hepatocytes to this, much more so than what you would see with metabolic enzymes, for example. And so if we look at, that was the change in message, can we correlate that to changes in function for this? And for this set of studies, we used our same model system, but this time expose these hepatocytes to cyclosporin, a potent BSEP inhibitor, for varying amounts of time, and looked at various parameters. So in the first graph here, we're looking at the biliary excretion of an endogenous bile acid, GCA. So this is generated by CYP7A1. It synthesizes cholic acid. Then it's rapidly conjugated to glycine inside the hepatocyte, and that bile acid is then effluxed by BSEP into the bile. And so we can see in the presence of a BSEP inhibitor, we see a very significant decrease, time-dependent decrease in the biliary excretion of bile acids. So we're blocking excretion of this bile acid into the bile pocket. We then, if we look at what's actually happening inside the hepatocyte, so here we're looking at the intracellular concentration of GCA, and we see that going up over time. So you're blocking the efflux of GCA, and the intracellular concentration is then going up. At some point, the intracellular concentration of these endogenous bile acids will get high enough to activate FXR. And this FXR then will lead to all of these other processes that we've been talking about: suppression of CYP7A1, induction of OST alpha and beta, and induction of BSEP. But of course, here we have a BSEP inhibitor on board, so that's taking that out of the equation. But we do see a nice trend to starting to increase the FGF19 messenger RNA expression for this. So we're again linking these changes in message with changes in function for transporters. And to further look at that, we've evaluated the intracellular concentration of two exogenously administered bile acids, D8 tarcholate and D5 CDCA for this. And when you just treat with DMSO, the intracellular concentration shown here in green or purple for D8 tarcholate and GCDCA remain very constant. But if you treat with CDCA, again, you're bringing on all these other pathways, and again, you see the intracellular concentration of those exogenously administered compounds go down because you've induced BSEP and you've induced OST alpha and beta, which are responsible for effluxing these bile acids out of the cell. So we're again linking expression and function for that. And you can reduce these pretty significantly to about 10 to 15% of control just after 72 hours of exposure for this. If we also look at the bile acid pool, so these are bile acids that are made in the hepatocyte. Again, in the control situation with just a DMSO treatment, you don't see any change in the intracellular concentration of this bile acid pool. But following treatment with CDCA, you can reduce this very significantly, again, down to about 10% of control. So this adaptive response that we're seeing is a function of three things: the decreased synthesis, and then the increased efflux transport, both across the basolateral membrane by OST alpha and beta, and across the canalicular membrane by BSEP. All these work together to decrease the intracellular concentration of these bile acids, which would then reduce their potential for hepatotoxicity. And so we've also have shown that you can model this. So again, if we take these transporter certified cryopreserved human hepatocytes, culture them, treat them with CDCA or vehicle control for 72 hours. We can then, at the end of the treatment, we can then look at the uptake and efflux of a model bile acid. In this case, we're using D8 tarcholate. We're looking at it both in the uptake phase and in the efflux phase, so we can get information on various clearance pathways. We do this in the presence of 4% BSA, so we can better reflect the in vivo situation. And then we simply measure the amount of tarcholate in both the cell lysate under the two conditions and in the media under the two conditions. And by fitting a mechanistic pharmacokinetic model, we can identify these various clearance pathways. And we're primarily focused on the clearance into the bile and the basolateral efflux clearance from the hepatocyte into the media for this. And Sen Guo had a nice poster at the ITC workshop this spring and was able to show that the clearance, the canalicular clearance under these induction type of conditions was increased, and also the basolateral efflux clearance was also increased under these conditions. And if we go back to the kind of normal state that we talked about earlier, bile acids again are taken up by NTCP. The majority of them are excreted by BSEP into the bile, but there's a significant component of the basolateral efflux. If we compare that to this, the induced state now, where after we have exposed these cells to higher levels of bile acids, we now see the two clearance pathways are approximately equal. So basolateral efflux clearance, that route is approximately equal to the clearance into the bile. So this basolateral efflux clearance change represents a very important adaptation pathway when the cell sees high concentrations of bile acids. And as an aside, as you saw in the previous talk on species differences, it's very important to have the right mix of these bile acids and to use human models, since the rodent models, again, differ in synthesis, metabolism, and regulation of these bile acids. You need to have the primary bile acids, but also secondary bile acids are important because those are generated in the intestine, and the liver sees significant levels of those, and they're also relatively cytotoxic for this. And also the conjugation, getting that right, is very important. And the conjugation is really controlled a lot by the media, so it's very important to have a media that supports glycine and taurine conjugation in human in vivo relevant ratios. And as you can see here, most of the conjugation it is to glycine, with a smaller fraction being conjugated to taurine. That's in humans. In rodents, most of the conjugation is with taurine. So it's very important to get that ratio right. And it's important to remember that, you know, all of these bile acids differ in cytotoxicity. So it's very, a pool of bile acids will better reflect the in vivo situation for that. And so this, I hope I convince you that the hepatocyte has a very significant potential to adapt to these higher level of bile acids. We've shown that you can initiate this adaptive response by BSEP inhibition. Shown here, we're looking at the OST beta messenger RNA change, and if we expose to a BSEP inhibitor, we can see a change in that, indicating that we've activated FXR. So we can do that with a BSEP inhibitor. We can also do that by adding more bile acids to the system. However, if we put these two together, we can see a very significant synergistic response because you're adding bile acids and you're also blocking their efflux. So that's when you generate very, very high intracellular concentrations of these bile acids, and you see this FXR mediated response for this. Now, there's also ways that we can impact the adaptive response. And so here again, we're looking at OST beta messenger RNA expression, the fold change for that. We can affect that with cyclosporin, with CDCA. Again, we put the two together. We see a very synergistic type of response. And now if we add other compounds to this mix, for example, triglycerin, which is a weak FXR antagonist, we can now decrease this response by about 50%. So if you compare the orange with the green bar here, by having triglycerin in there, we're blocking the response of the hepatocyte by about 50%. If we then add a much more potent FXR antagonist, such as DY268, we can decrease that response even further. So by having an FXR antagonist on board, we can actually prevent the hepatocyte from responding to these high intracellular concentrations of bile acids. And this would increase the potential for cholestatic hepatotoxicity in this situation. So if we want to look at cholestatic hepatotoxicity in a in vitro model, we really need to integrate multiple mechanisms. And so here I'm showing you bile acids are taken up by NTCP and excreted into the bile or bile pockets through BSEP. If we block BSEP, we now have eliminated the primary route of elimination for these bile acids, but we still have some going out through MRP3 or MRP4. But when we block BSEP, we then see an increase in the intracellular concentrations of bile acids. At some point, these bile acids will get high enough in concentration to activate FXR, and this will bring on board, as we've shown you, OST alpha and beta, which can then efflux these bile acids out of the hepatocyte. It will also increase the expression and function of BSEP, but since you have a BSEP inhibitor on board, that route is much less important for this. And so when you bring on the basolateral efflux transporters, the intracellular concentration of bile acids will go back down or reach some new type of steady state. If then you have an additional insult, such as an FXR antagonism, as I've shown you, and or you inhibit the basolateral efflux transporters, either MRP3 or MRP4 or OST alpha and beta, now you've blocked all of the efflux pathways for bile acids, and you've blocked, if your compound is an FXR antagonist, you've blocked the ability of the hepatocyte to respond to any of that. And that's when you'll see these very, very high intracellular concentrations, which will then be toxic to the hepatocyte. So to summarize, what you really, in order to predict cholestatic hepatotoxicity, you need a human-relevant model that has human-relevant bile acids in there. You need to integrate multiple mechanisms, both on the metabolism side, on the transport side, and on the regulation part for that. And your compound must affect multiple pathways for this. So BSEP inhibition plus perhaps basolateral efflux inhibition and or FXR antagonism. So integration of these multiple pathways in an in vitro system is going to be key to predicting clinical effects of your compound for cholestatic hepatotoxicity. And I'd like to end there, and again recognize a lot of the people who have done a lot of the work in this area, and I'd be happy to take any questions for now. Thank you.
All right, thank you very much. And we have some questions already. The first question is, given that bile salts are able to modulate expression of basolateral efflux transporters, MRPs, would the lack of MRP upregulation in SCHH be indicative of partial insensitivity to cholestasis of the SCHH system, or that perhaps the increase in bile acids did not achieve the necessary threshold to trigger MRP response?
Okay. Yeah, so you notice when we looked at MRP3 and MRP4, under these conditions, we did not see any changes in there. And we exposed with bile acids, particularly CDCA, up to about 100 micromolar. We can go higher with that before we start seeing toxicity, so it may be interesting to look at if you go higher, then do you begin to see upregulation of some of these other basolateral efflux transporters. Right now, all I can say is in our system, under these conditions, we don't see changes in message. Now, that's not to say there would not be changes in function for that. We don't currently know a lot about correlation between changes in message and changes in function. We do know a lot of these transporters move on and off the membrane, so it could be possible that you could see functional changes without seeing changes in message.
Okay, any other questions? And I'd like to point out that the slide notes will be posted, sent to you after this talk, so they can be the animation can be fixed. And we have another question. So, when evaluating a new development candidate, would you first study BSEP inhibition, and if there is any sign, investigate FXR regulation and OST inhibition? If there is no inhibition of BSEP, the risk of cholestatic hepatotoxicity can be considered as low?
Well, I would say we don't know that yet. If there are other, right now, all of the data that we have suggests you need to have BSEP. You need to have BSEP inhibition, or the examples that we have show that if you block, if you inhibit BSEP, you see this increase in intracellular concentration. We don't know yet if you would say increase, if you would inhibit basolateral efflux, would that cause an increase in intracellular concentrations of bile acids? I don't think so, but it may. We really don't know at this time. And actually, the next talk in this series is going to be dealing with that. Are there better ways, other than looking at BSEP, to predict what the potential of a compound is to cause these various types of cholestatic hepatotoxicities? But all the examples that we have now suggest that BSEP inhibition is important, but it alone does not predict that. So you would need to have, you would need to look at these other pathways for that. One of the primary issues is there's not, commercially available assays now for, say, OST alpha and beta. You can look at FXR regulation for that, but the important thing to remember is that it's really the interaction between all of these processes that's going to be important in predicting the effects of a compound. So taking things apart, using different assays for different mechanisms here, you still have to put them all together. And what we're going to be talking about next time is an assay that integrates all of those together to give you better predictive ability.
Okay, another question. What do you think the function of OST? Efflux transporter or uptake transporter? And what is the relationship between MTCP, MRP3, and OST?
Well, the OSTs, I think, can transport things in both directions, and it's it's going to be a function of the concentration. Normally, OSTs were thought not to be that important in the liver, just because they're there at very, very low expression levels, and so the function, would appear to be, very, very low. But when you, in this induced state, when the cell is responding to these high intracellular concentrations of bile acids, I then think they become a lot more important and represent a very significant mechanism for the hepatocyte to get rid or decrease the intracellular concentration of these bile acids. We, like I said before, when we looked at expression of the other transporters of the OATPs and of NTCP, Again, we didn't see any changes in those, but again, I'll emphasize that's in message, and I think there's a good body of literature for, especially for NTCP, that is one of these transporters that can move on and off the membrane, and so you can get changes in function without necessarily seeing changes in expression, and I think that's always good to keep in mind.
Okay, and another question. Just curious, have you investigated FXR activation and transporter changes in SCH from other species, for example, a rat, mouse, or dog?
We've done those in rats. That hasn't been published yet, but I can tell you that it is different than in humans, and that's why we focus most of our work in human hepatocytes, because the rats regulate the transporters of these bile acids very differently. They also have, as was mentioned before in the previous talk, they also have different metabolic pathways. So most of the rat bile acids are conjugated with mercolic acid, which is transported differently and is very much less toxic. It's one of the least toxic bile acids for that. So there's very significant species differences here, which is why we're focused almost exclusively now, at least, on human hepatocytes.
Okay. Are there any other questions? Let's see. Going once. Going twice. Okay. Well, thank you very much for participating today, and this recording will be available for listening later. And like I said, I will distribute the slides once I have them. So with that, thank you, Dr. Brower, and have a good day.
Thank you.